Thank you for joining us. We have attendees, as I mentioned, from all across Africa. We have 310 registered. We have over 130 now on the call, and we should get started. So as we move on to this webinar, the effective use of technology to flatten the COVID-19 curve in Africa, I would like to welcome the panelists that are on today's webinar. Let me begin by introducing and welcoming our panelists in turn. That's me. I'm the chairman of Africa Health Business, and I want to turn it over to the man who is leading the Africa CDC and creating this continental strategy to ensure that we keep Africa safe. Dr. John Nkengasong, over to you for introductions. So John, just a few words from you about yourself would be great if you can hear us. It's really a delight to have Ernest Yu on this panel, and over to you for your introductions, please.
Thank you, Dr. Taka. It's a pleasure to be a part of this esteemed panel. I'm Ernest Darko, one of the co-founders of Broadreach. We are a healthcare management and services company focused on improving the health and well-being of populations around the world. And we try to do that by leveraging cutting-edge fourth industrial revolution technologies and figuring out how we can use those to improve individual and population health at large scale. So I'm really excited to be on this panel, and thank you for having me.
We will be joined also by Dr. Fikele Ndlovu, who is the Deputy Director in General on Macro Policy and Strategic Management, Monitoring and Evaluation from KwaZulu-Natal. But as we get on with the use of technology to flatten the curve, let me try and set the stage, not to take on what John is going to speak about, but to just say that this is a trying time for us in Africa. As you all know, the curve is mirroring Africa. The curve in Africa is mirroring Europe, and all the countries are currently busy with their national strategies to try and flatten the curve by curbing the spread of COVID-19. The strategies on suppression, lockdown, in some cases, restricted movement, are all being explored. Imported cases were the biggest original infected cases that our countries saw. When we reported the first case in Egypt, and then we saw some in North Africa and then South Africa, these imported cases were mainly travelers, and that's known as the first curve. Many countries are now dealing with that first curve, hopefully seeing the curve flatten, but those travelers have been in contact with people in their own countries, and some of these positive cases are being noticed in many countries. Everyone who's trying to put in the national strategies is trying to avoid local transmission. And we know that the vaccine is the ultimate solution, and it's many months away, possibly about 18 months away. And there have been lots of discussions around treatment and the antiretrovirals. But the biggest thing here is testing. And testing is going to be the game changer. The more we test and the more we identify the populations at risk, the better we will be in stopping local transmission. We know, we've seen the hockey curve, we've seen the inflection points in many countries. What we're trying to do in Africa is to buy time. And that time will help us strengthen our health systems to appropriately manage the patients when we get the surge. We need all your support. We need all stakeholders involved in trying to ensure that we keep the numbers down and we get enough time to prepare our health systems. We know that we have a challenge in our health systems in Africa. We know that they wouldn't be able to cope with the surges that we see across the world. So all the champions and leaders that I see who've attended this call, the call out to you is, let's work together with the government, supplement the Ministry of Health efforts, identify the risk populations, practice social distancing, the use of masks and personal hygiene appropriately, and protect our health workers so that we can deal with this surge when it's appropriate. One of the areas that's very important for us to work with is technology. The private sector is definitely a leader in technology. Innovations have happened all around Africa, M-Pesa being one of them in Kenya, and lots of other technology advances that we've seen. One of those would be the analytics and identifying through contact tracing and looking at the vulnerable population. If we keep the deaths down and we prevent deaths by using technology and partnering with innovative companies, we can go a long way in ensuring keeping Africa safe. With these remarks, I'd like to turn over to Ernest. Dr. Ernest Dacro is the founding partner of Broadreach. They've got brilliant experience when it came to the HIV outbreak in South Africa. And today, Ernest will take us through some of the innovations and improvisations of his system that can meet the COVID-19 battle that we have. Dr. Ernest, over to you.
I'm just happy to signal that I think.
Oh, wow, John, you managed to come on board.
Yes, managed to come on board.
Let us start with you, John. I was trying to paint that picture of Africa. You may have heard part of it, but for the listeners and the attendees, we would really like to hear from you. What is the current status of COVID-19 in Africa? Let's start with you.
So, thank you. And again, my apologies for the technology challenge. It's not in lack of literacy on my part. Is I think the computers that we tried 3 computers or devices and it just didn't go well. Let's move. Approaching 19 cases reported for 52 of our 55 member states. We are also approaching 1,000 cases there. At this point, I always pose to signal a warning that we shouldn't be too much into these numbers because this is a treacherous virus, this is a mischievous virus and a dangerous virus. We know the situation, if I can just use one make my point. On the 1st of March this year in the United States, we were less than 200 or even less than 100 cases with at least a couple of deaths. And 1 month later, we know that we are 1.5 months later, we know that we are around 30-something thousand people dead, almost with more than 500,000 people infected. So the virus tends to give you a false sense of complacency that everything is under control. It enables itself to spread in the community, and then when it blows out, it seeds itself into vulnerable populations and then explodes. I think that is where we should be extremely vigilant. Based on that, we need 2 things for the continent. One, we need a continental structural approach, which calls for a coordination, which calls for cooperation, which calls for effective collaboration, and that calls for communication. That's exactly what we've done. The ministers of health assembled rapidly on February the 22nd in Addis Ababa under the leadership of His Excellency Mustafa Faki Mohammed. There were 2 main outcomes from that meeting. First was an urgent need for a coordinated continental strategy which has been developed, and it's underpinned by 3 pillars. The first pillar is for us to limit transmission as much as possible. The second pillar of that continental strategy is to limit deaths. The third pillar is to limit harm. And I use harm here in a very broad sense. Harm, I would like to comment on that a little bit, the economic harm. Secondly, the health-related, the non-COVID related harm, and also the human rights harm that this may result to. So those are the 3 cornerstones of the continental pillar. At the more technical level, I think there are a couple of things that we can do. When the situation gets tough, and when you're at war with what we are, with the current situation we are, because we are indeed in war against the COVID-19 on the continent. It's a war that we must win to survive. I mean, that has to be said and said very clearly. There are a couple of things that are outside of my hands, but there are a couple of things that are within our reach. And there are 4 things that we can do, and that are within our reach. First, we can expand testing and identify individuals that are at risk, test them, know their results, isolate them, and develop a system using everything available, including technology, to trace their contacts. Second, we must prevent and protect our public health workers. We already know that the doctors are dying already, even though our numbers are small. In my native Cameroon, over 20 doctors have been infected with about 3 deaths. We can't afford that. If we do that, then we amplify the harm piece of it. Then we can't fight the second. We cannot implement the second pillar, which is preventing deaths, and we cannot even achieve our goals of the first pillar, which is to prevent or limit transmission. The third thing we must do is to engage, to have a community response approach. This is the whole of government and the whole of community. It starts and ends in the community. So we have to bring the community in the broader sense together. Community here doesn't mean the underprivileged or vulnerable population. It means all of us. It means bringing the private sector to bear, and that means cooperation with the private sector, cooperation with the vulnerable population, cooperation with the remote areas of the communities or countries. That is number 3. The last piece we have to do is to develop effective partnerships. Effective partnerships that will bring innovation to this space. There is no one a method that or approach that will enable us to win this war. We have to use all approaches, including, and very importantly, the role of innovative technology on how to reach our community, on how to improve the turnaround time for testing, on how to do contact tracing there. So those are areas, critical areas that are required to combat this virus there. And I'll conclude by saying this, that the fight against COVID-19 is a war that has to be fought locally, but the victory has to be a global victory, which means Kenya, for example, cannot declare total victory over the COVID war if Tanzania, Uganda, or South Africa still has cases. It means at some point we need to start the struggle at zero. So let me just end here, and I'm looking forward to a very interactive and dynamic conversation. Over.
Thank you, John. I'll repeat for those who might have got a fluttered signal. And John said 4 things that are very important. Things are within our reach. And what I heard from John is expand testing was critical, prevent infections to the healthcare workers so that our front line is strong, commit our response to the community action. And the community is all of us. It's not just the vulnerable, and this community action will help us. And fourthly, effective partnerships. And John closed by saying, no single country can claim victory, and no single country can claim that my numbers are going down. No single country can show a knuckle that means the numbers are going down. We need to fight locally, but we must win globally. So this is one of the key takeaways from the continental strategy, besides the 3 pillars that he mentioned, is we should all be asking ourselves, what are we doing for those 3 actions? What are we doing to reduce transmission? What are we doing to eliminate death? And what are we doing to prevent harm? That probably, John, could encapsulate your summary. Based on that, I would like to move on to Dr. Ernest. This particular session was really about what can we do more effectively with technology, and we know private sector is a forerunner. So you are one of the players on effective partnership in countries, not only in South Africa, but across Africa. Tell us something that we can do to help us in this battle. Over to you, Dr. Ernest.
Thank you, Amit. As we've seen, COVID is using our faults and weaknesses in our health systems and in our social systems, essentially as its highways and byways through which it travels and wreaks havoc. And the root cause of these weaknesses are poor leadership and poor management, and the inability to quickly and effectively link all the various systemic supply and demand side dots that must come together for effective service delivery, right? There's many, many aspects. The supply chain must work, drugs must be there, you must have enough health workers, they must be trained, you must, understand where the disease is spreading and act at the right places at the right time. And this is usually exceeds the ability of the human brain to triangulate across all this information that's evolving in real time, and make the right decisions in order to maximally deploy your scarce resources in the most effective way to flatten the curve. So we basically developed a technology platform in 2013 called the Vantage platform. And we developed it really specifically. This was based on, at that time, about 10 years of working with various different governments, primarily in emerging markets, on how to fix health system. And what we felt at the time was that the most common single thing we always encountered was decision makers and leaders and the healthcare system essentially didn't have the right information at the right time to make the right decisions. And then secondly, on the flip side, when it came to implementing effective programs, they struggled because we don't have strong, good supervision of staff out there. We don't have many qualified supervisors to do this. And trying to do mass supervision manually is a gargantuan task where you have to have very high quality managers who are out there overseeing all this work. So we tend to be weak on both fronts, sadly, meaning not knowing what's going on in time to respond appropriately. Secondly, when we do need to respond, we're not that good at actual implementation on a Monday morning. We may have a good plan, but when it comes to how do you make sure it's being implemented effectively with fidelity everywhere it's supposed to be implemented, we struggle to do that well. So we decided that we realized that this is an area where at that time the emerging fourth industrial revolution technologies like artificial intelligence and machine learning could really help us by, first and foremost, using big data techniques and aggregating data to give you the right insight. So the concept is we must be able to gain the right insight at the right time so that we know we're acting in the right places, in the right ways, right? So just being able to triangulate across this data, the machine can do it, a human being cannot. I always give the example, even in my company, if I take my most experienced public health managers and give those managers the same 5 graphs and say, what does this mean? I'll get 5 different answers, right? So, and yet, to someone as experienced as Dr. Ikenga Song, for example, and Dr. Fikile Ndlovu on this call, they would probably interpret those graphs correctly, right? So there is a correct interpretation, but when you leave it to multiple people to try and interpret it, you find it's very difficult. In particular, when you get to our leadership in most of our countries, when we talk about minister level and permanent secretary level, they're not supposed to be data analysts, right? They're supposed to be people who run the health system fed the right data and analytics, but we tend to try and make them into data analysts. So we felt that we need a platform that can provide this aggregation and interpretation for them in simple English. For example, telling you, focus on these 3 hospitals because they're causing 75% of your gap. And to have that in real time, so not based on a quarterly report or a 6-month study you hired a consultant to do, but at any moment to be able to click a button and it tells you, these are the 5 hospitals causing 74% of my gap in this indicator. So we designed the platform basically to do that, to give them the right decision support, the powerful insight that allow them to make the decisions. And then secondly, we said we need to address the implementation side of how do you implement large-scale programs with fidelity. And that's when we basically program the platform to be able to monitor daily, hourly, or weekly activities of staff in the field. And you can monitor what they're doing in real time. And they follow menus that have been sent to them on their devices, so you know they're implementing that practice or activity properly and with fidelity all the time. And when there's pockets of staff who have not implemented those steps, the AI and machine learning automatically alerts the manager as to these 3 staff, for example, have not started their steps. You must follow up. So based on this application, we've rolled it out in 2014. It's been 6 years of hard lessons of what doesn't work. And we finally believe that we've gotten it to a point where we know what works and we know what doesn't work. And the platform was deployed against, like I said, HIV, TB, malaria, and diabetes programs in South Africa and a number of other African countries. And when COVID came, it just so happened that many people then turned to us saying, look, you already have a system on the ground, for example, where you're monitoring the activities on a 2-hourly basis of what staff are doing in facilities and in communities. Now with COVID, for example, we need to actually do facility assessments to see if they're ready. Can you actually do these assessments through your platform? And of course, since we're already gathering constant information from the facilities, it was very easy for us to quickly gear up and provide those facility assessments. Secondly, then they said we need to go out and screen and test our communities. And we already have staff with using these devices in communities doing activities like screening, follow-up of patients who are missing, etc. And so we were able to then quickly program the community survey into these applications where staff then go to the door and they're able to begin the screening immediately. So for example, in South Africa, within less than a week of the president announcing the screening campaign, we were already launching the screening at large scale with 4,500 staff doing that screening across the country. So you ask, what do we need to do? I think one is we need, whether it's our Vantage technology or not, we need to leverage effective technologies that are out there that, in essence, allow us to gain the advantage against the speed and ferocity of COVID. We need to be able to take these technologies and bring them into play quickly, scale them up. And I'd say these are technologies that had to have had some hardening, some provenness, because this is not the time you want to be starting to learn the lessons we had to learn over 6 painful years to get it right. So you need technologies that will work, that can be scalable very quickly, and that can add value at scale. And then beyond the analytics, we also need a whole swath of other technologies, as you can imagine, for testing, for diagnostic technologies, for cleaning the environment, whether it's air purifiers that will kill the virus in clinics. We need a whole, new medications as we're learning more about the virus, etc. So a whole swath of other technologies need to be lined up, and the supply chains for those need to be set up so that they can, again, reach where they need to reach in time to save lives or to mitigate the damage of COVID. So from my perspective, technology is our ace in the hole if we get it right. And we acknowledge that the world has really changed. And that change means we have to change with it. And technology gives us the ability now to do things in a new, more effective way for COVID, but also beyond COVID. When we go back, hopefully, to normality, we can tackle other diseases better as well.
Ernest, I want to jump in and ask you, those who are listening, who may be part of the national visit, and how, with these travel restrictions and support, how easy is it to apply some of these technologies to ensure it's effectively done?
In our case, for example, we're all under lockdown. We're in one of the strictest lockdowns, I think, on the planet in South Africa. I physically have literally not left my home in the last 3 weeks. And we've been able to deploy all this in remote locations with all of us locked down. And we've been able to deploy these in sometimes 2 days, sometimes a week. If the criteria is there, for example, that there's guidelines, for example, in South Africa that say these are the things we need to screen on, we can still deploy very quickly without being there. That's the beauty of technology, that a lot can be done remotely.
Dr. Ndlovu has also joined us. So, Dr. Ndlovu, can you hear us? Can you speak so that I can ask Ernest?
Hello. Hi, it's Siggy on the side, Dr. Ndlovu, and I can hear you very well. Thank you.
Ernest, could you hear her?
Yes, Ernest? I can hear her. Yes, I can hear her.
John and Ernest, I hope you can hear Dr. Ndlovu because she's joining us remotely using the phone. Dr. Ndlovu, tell us your experience in KwaZulu-Natal and what do you think and how do you think this technology is being applied And what is your message to the attendees who are here from the rest of Africa? Go ahead.
I think, firstly, I would want to reiterate that the technologies are technologies that did not start now with the COVID-15. We've actually been working on these, looking at community-based, what I would call a comprehensive approach to health, and saying to ourselves, if you were delivering on health, what are the things that you need to put together, including technology? So I think there is that background in terms of what we are talking about now to COVID-19. So when COVID-19 came in, it only makes sense that you are then able to adopt what you already have as a system. That is working, that you've got, for example, the question you were asking to say how easy is it to deploy. But remember, it means you must have had some machinery that in terms of human resource who were used to working with you, who understood, who are able then to latch on that technology that is there. So that is the first thing. And I think the message for me that is very important for us, especially who are in government, is saying, what are the things that we already have? When we talk about technologies, it's what are the technologies that we already have, or what are the technologies that are already there that are working in our scenarios in Africa that we will be able to apply. So this would be one example. But also let's look at all the technologies that are available that go beyond, because I think ultimately COVID is going to test us a bit more. You want your health system to be in place, but you want your social system to also be in place. And what are the different technologies that we are able to then put together, or technologies that allow you to put together a comprehensive approach in terms of COVID-19? And I think that was the experience that we already have with this technology that allowed us to be, and also be confident that we'll be able to work into a comprehensive approach towards health.
Thank you so much. It makes it so clear. I would like to move over to John. John, can you hear me? If your signal is clearer, just...
Yes, I mean, I can hear you.
Yeah, okay. Your signal is a bit fluttering, but I think we'll be able to capture a few points. In your opinion, at the Africa CDC level, what is your experience of technology? And you keep also insisting that we have to do testing and we have to have the risk groups really identified. How is it working currently at the Africa CDC level?
I think at a level it sees so much the traditional contact tracing methods that we are using, which is to identify a case, suspected cases, you test them, and then you isolate them and do their contacts using the manual standard textbook approaches, not technology-driven. So I think what I'm hearing from this sounds appealing, and especially if they have been tested in South Africa, Africa CDC will be more than happy to take that model and try to replicate it in a couple of countries quickly. I mean, the key word here is quickly, because we just don't have the time to lose. Over.
Yeah, I think that's great. And I might ask you, John, there'll be somebody from our team who might call you on the phone, and we might try you on the phone for the next few minutes. We'll try to see if that's clearer. But let's move quickly to Ernest. Ernest, on your application, in terms of the vulnerable groups, do you think that this application will help outline those who have not used it? You know, Dr. Dlovu also said that people should use the technology that they already have. And some of the countries who are online just now may not have used an application that you might be calling Vantage. How will you help them if they haven't used that sort of a platform to identify vulnerable population?
Okay. So at the moment, these are the use cases we've built into the Vantage platform to support the response against COVID. And we've broken it into demand side and supply side. Supply side meaning the health system, and being ready to respond appropriately. But the demand side is the community side and the things we need to get right on that side. And so, as you can see on the demand side, we've built the application to be able to do the screening and testing and to aggregate and geomap that data in real time. We then also have built into that application a way of now doing the contact tracing. So as you find individuals, you can do the contact tracing as well through the system, and also geomap those. And then managing high-risk populations, which goes to your question. So in South Africa, unfortunately, we are in a situation where we have the largest single country HIV population in the world. Of all of the HIV on the planet, 25% is in South Africa alone. So out of our population of 55 million, we have about 8 million people infected with HIV, which is insane. So for us, the issue of immunocompromise and what this virus might do is really something very critical. And so what we were doing with Vantage for HIV was using predictive analytics to determine which patients were most at risk of treatment failure, of dropping off treatment, because then those would be most vulnerable. And the population we as a partner in South Africa manage at the moment is about 500,000 patients who are on HIV treatment. So with our population, we'd run the algorithm and it will point out, it will list these are the individuals who are at most risk, and then we'd reach out to them by SMS messaging, etc., provide more intensified support for them to make sure they stay on treatment. So for vulnerable populations, there's the predictive analytics piece, but there's also the practical piece of what's going to fall out of the screening. So we're screening people for age. If you're in the older age group, which you know is a risk, we're screening whether you have comorbidities like diabetes and hypertension. And so between the predictive analytics and what comes out of the screening, we'll be identifying vulnerable people. And then we know that those people need extra measures, whether it's self-quarantine or to make sure that they're taking their medications properly so they're in peak health when they get infected. And we know it will be quite likely that most people will get infected over time unless we come up with a vaccine. And then finally, we've built in the epidemiological surveillance components where decision makers, we feed into a national command center, and all of the country data then is aggregated to make decisions again at a national level where it needs to go. So in terms of using the system, it's extremely easy. When somebody needs to use it, it comes with a quick training video that you can just download and watch on how to use it. But these applications are very simple. It's just that they enable you to do large, simple tasks in a large scale way, systematically and with fidelity. And that's where the power comes from. Not really complicated to use.
Thank you. And I know Dr. Ndlovu has a lot to say on that. I want to move to the Q&A sections. I've got a few questions coming in. And John, I want to start with you. There's some questions about hydroxychloroquine. Everybody's talking about it, and it's not related to technology. But where does Africa CDC stand in hydroxychloroquine? Question one.
Can you hear me?
Yes, it's a bit better.
Okay, good. So we issued some guidance on that, and a statement saying that we don't yet have evidence or clinical trial evidence, which is the holy grail for any recommendation that hydrochloroquine or chloroquine can be used extensively. As we speak, there's one registered clinical trial in Africa that is going on, and we have to wait for those results. And we also have in the Solidarity trial that we're conducting a couple of so our recommendation is that if you want to enroll in it, if you want to use it, you better get enrolled into a study protocol. That way you can be monitored carefully, because it has some severe side effects, including the hospital effects. Of course, the French study that we did shows that there is no benefit, but it also shows that high risk for secondary effect, including cardiovascular. To summarize, the conclusion is that have the evidence, and then we can use the evidence to do anything to drive our decision. Over.
Okay, I might need to ask you that question again. There were many breaks in that answer. So if Kiran, can you call John on the phone and repeat that answer using a phone? But in the meantime, while we try and get John on the phone, there is a question for Ernest that how do you get data inputs for this program? Is this looking to access electronic health or clinical resource records? Is data sufficiently digitalized? So tell me about it. What are interoperability between different data sets? So there's a lot of data question, Ernest, for you.
So, so for the COVID application, when you take, for example, community screening and testing, that is coming in directly through the app in electronic format. So it's real time capture and real time analytics and geo mapping of as the information comes in. That said, for outside of the COVID context, a lot of the initial data sources are on paper. But because of the approach we take where we focus on trying to answer a specific management question that people need in order to manage and govern better on a Monday morning, we don't need you to collect all the data that's from those paper records. We just need one or two elements in order for the algorithm to grab onto and produce an answer. So our system is able to grab elements that are on paper, elements that are in Excel, elements that are on PDF, elements that are in databases like SQL, etc. And then in some cases, we'll link through a direct electronic API link into somebody's system, should they allow it. So it's very flexible in terms of being able to start with you where you are, you know. And so, for example, when we started this program, we've rolled out with real-time capture, but some capturing had already been done on paper forms. And we're able to now back capture some of that into the system so that we get a more comprehensive data set on a go-forward basis. So it's quite flexible in that manner. And that was one thing, having worked in this environment for the last 20 years, I felt it was important that anything we build with technology must still be able to work with the paper model, because most of our systems are on paper at baseline.
Okay, thank you. John, are you able to repeat that chloroquine question because it's pretty heavy?
Yes. So I was saying, I said we've issued a statement and provided guidance on how hydrochloroquine should be used. And essentially it's saying that this is a drug that has not been proven through clinical trials, because there are two things that are required for us to make any recommendation. Is the drug safe and is it efficacious? And we just don't know the answers to those. The only way that you know that is through what we call a double-blinded clinical trial. And we are hoping that it will be that we will get the results once the trials are completed. I also indicated that in Africa there's one registered trial that is going on in South Africa. And until we know those results, it's difficult to make a broad recommendation. Lastly, we are saying that if people want to use the drug, you better be in a clinical trial setting. That way you can be observed carefully, because there are some severe side effects of these drugs. Over.
Thank you so much. John, there is another question for you here, and that is, how can Africa CDC support scale up of the various technologies in this national and the continental fight so that we can fight locally and win globally? Any input from you would be useful.
I think there are two things we can do. One is we have the convening ability to bring countries together, share that information and experiences, and then provide an avenue that will enable the countries that are interested in the technology to advocate for it and use it, what are called early takers. I think that's one way we can help with that technology and do that quickly. And we can actually, as of next week, convene a certain number of countries across the 5 regions and expose that technology to them. That is one. The second thing we can do is to enable countries to begin to implement them. That is, besides South Africa, where the technology is, we pick a certain number of countries and support them to implement the technology. So those are the 2 ways Africa CDC can contribute in scaling up the technology.
Thank you. Dr. Dlovu, are you on the line? Can you hear us? Okay. There is a question for you that we've got from the audience is, what are the main challenges in the field of technology that US government entity face in the current times of COVID-19? Over to you, Dr. Dlovu.
I think overall, I would say for us, for example, in technology, it's the issue of connectivity. If you think that we don't have all our areas rightly connected, we need connectivity. So those are the things that we are finding overall in terms of the technology. There is a challenge that South Africa is trying to address it. That's the first area. The second area that I think more I think that's our main challenge, because I think the technologies can be developed, but as soon as you have a challenge in terms of connectivity, then you sort of get left behind. That's the first thing. The second one that I think we are working on is the issue of integration. I think you raised it in your previous question, where you are saying the data is coming in all forms. How do we make sure we integrate and integrate our systems? I think that is our second layer of challenge that we are looking at. But it's also forcing us to look at the system in terms of integration overall going forward.
Thank you. Thank you so much. Dr. John, there's a question. There are complementary solutions on the continent. How do we introduce these to Africa CDC for inclusion, for solutions that countries can take? I think it's similar what you answered earlier, but there are many other solutions. I'm sure many attendees are in IT and technology are saying that it may not be one size fits all. So there may be complementarity in this. And I heard from Dr. Dlovu, I think broadband is a challenge. And Dr. John, what are we going to do and what are the thoughts behind this? Over to you.
Yeah, thank you. I'm assuming that that the quality is better now. Through the continental mechanism, which the ministers of health established, and that mechanism has been endorsed by the Bureau, we have a task force, what we call the AFCON, the African Task Force for COVID Preparedness and Response. And underneath that, there are several technical working groups. I would strongly advise or recommend that if there are technologies, people should channel that to me, and I will direct it to the appropriate technical working groups so that they can look into that carefully. The technical working groups are not just CDC, they aim to derive and harness all the assets, the human assets and public health assets that exist across the continent. So they are really top experts that will look into this and advise how to move that forward. So I think in some, if people have technologies or any other aspects they want to contribute, there's a platform for that, which is the African Task Force for Coronavirus Preparedness and Response. Over.
Thank you. I would like to ask the panelists to give parting shots. We can't answer all your questions. This has been an engaging 1 hour on technology. We will continue working on the private sector mobilization efforts to support the Africa Union, Africa CDC, Ministries of Health in all the countries. We will mobilize the private sector when it comes to testing, treatment, as well as hospital preparedness. And that is the function that AHB and Africa Health Business will play for you on a regular basis. I would like Dr. Ernest to give his parting shot, and then I'll move to Dr. Ndlovu, and we'll end up with Dr. John giving his final words. Ernest, over to you.
Thank you, Amit. The situation that we're in at the moment really, it feels like a crucible moment, And a crucible moment is, by definition, a transformative experience through which an individual or a society comes to a new or altered sense of identity, right? And these are times of great adversity where our character is tested, and either we're going to emerge better and stronger and more resilient, or we're going to let it destroy us. I think the latter is not an option. We have to win this at all costs, and therefore we have to use all the tools at our disposal. But we have to do this in a different way, because we tend to fragment and silo things. And the worst thing we could possibly do is now make the COVID response become another vertical silo that doesn't integrate with any other thing, right? And then it becomes something later again that we need to integrate in. So I think it's an opportunity to use COVID as an entry point to improved primary health care, as an entry point to improved universal health coverage, because that we have to get it right holistically so that we're immunized against the next epidemic. If we do it again as a single point response, we'll be vulnerable to the next thing that's slightly different. If we get the platform right, the service delivery platform right, and strengthen it with all the technology know-how we have, then we can truly be immune from other shocks and threats that are to come. So thank you. I'd like to honor all those we've lost so far. I'd like to honor our health workers who are putting their lives at risk every day. And I'm honored to be participating in this response in whatever small way that I can. Thank you, Amit.
Thank you, Ernest. The crucible moment is really a take-home message. Dr. Dlovu, your parting shots as we wind up this webinar.
I think I just firstly want to say the important thing from the COVID is teaching us is a stronger collaboration and integration, especially collaboration in the business sector, in light of the conversation we're having. How do we make technology be real in Africa? And COVID is giving us an opportunity to do that, to leapfrog. Therefore, for me, the business sector becomes very important as you raise the issue of connectivity in any form, whether broadband, whether the different 4G, 5Gs, to say, how do we bring Africa? Because this is forcing us. This is an opportunity for us to walk back and look back at COVID and say these are the things that we achieved. But we will not be able to achieve that as government alone. We need the private sector, but private sector needs to come in as a partner in the fund, and not just from a capitalist perspective of saying how much profits they make, but of saying how do we make Africa better. Thank you.
Thank you, Dr. Dlovu. When somebody the other day said it's not only for fighting COVID in terms of the Ministry of Health, but broadband and connectivity keeps us connected when we are staying at home, staying safe, and broadband keeps us going for edutainment, education, and getting the right information and knowledge. You are spot on about that. We've been doing more of Zoom calls and seeing people live. Never, ever before have we done so many calls like this. Dr. John, parting shots from you as we wind up.
I think this is a time I agree with what Ernest and the other colleagues have said. This is time for greater collaboration and cooperation. It is not the time for us to wear our flags like the private sector, just see what the future, but it's time for the unity of purpose as Africans to fight a common enemy and use every aspect that we have to fight as we before. And I'm very convinced we'll do that if we work collaboratively and cooperatively.
Thank you. I think John said that we have to fight the common enemy. We have to remain united as partners. And this is not the time to point fingers of this person did so and so. We need to be part of the solutions. Maybe some governments are blaming WHO, and maybe WHO is blaming other governments, and many institutions are blaming. This is not the time for blame game to all the presidents and political leaders. I think this is time for solutions, and we need to be part of that together, whether you are a global institution, African institution, or head of state. This is the only way we'll fight COVID-19. Thank you everyone for being on this call. Thank you for being on the webinar. And I think together we'll be safer. Take care.